Welcome to our presentation, All in the Family, 75 Years of Diabetes. We're going to discuss treatment options from glass syringes to SGLT2 inhibitors. Hi, I'm Peter Kreckel. I'm an adjunct assistant professor of pharmacology in the Physician Assistant Sciences Department at St. Francis University in Loretto, Pennsylvania. I'm also a pharmacist in an independent pharmacy, Thompson Pharmacy at Broad Avenue in Altoona, Pennsylvania. Let's cover our learning objectives for our program. At the completion of this activity, the participant will be able to review the morbidity, mortality, and cost burdens that result from inadequate management of type 2 diabetes. We'll describe the challenges of instituting insulin therapy based on a patient's perspective of insulin therapy. This will include a lot of my own family stories. We'll list the key differences between oral medications available for the treatment of type 2 diabetes, including efficacy, safety, and tolerability profiles, and we will discuss adherence counseling techniques to encourage people with type 2 diabetes mellitus to be part of their healthcare team. Let's look at this slide, which is an age-adjusted prevalence of obesity and diagnosed diabetes among United States adults aged 18 years of age and older. We'll look at the top 3 maps of our country, and we'll see the obesity epidemic has increased dramatically from 1994 through the year 2000 up to 2010. We'll see on the bottom 3 slides how the increase in prevalence of diabetes parallels that increase in obesity. When we take a look, say, at Florida, for example, we had less than 14% were obese in 1994, and that changed to an orange state in 2000, and then in 2010 we can see it's a red state with over 26% of its people being obese. When we look at the diabetes slide, we'll see that it was roughly 4.5 to 5.9% had diabetes in 1994, and in 2010, well over 9% of the population of Florida had type 2 diabetes due to that increase in obesity. This next slide for me is very dramatic because it starts in 1958, and that's the year I was born. And when we look at 1958, we'll see that the percentage of the people in the United States with diabetes was 1%. Now, the last year we had data for, 2010, we had almost 25% of our population has type 2 diabetes. Really, you could almost say a 25-fold increase in type 2 diabetes because of the obesity epidemic. Let's talk about the costs of diabetes, and so many of us directly involved with the healthcare as well as billing insurances will find out how expensive this disease is. The national cost of diabetes in the United States in 2007 exceeds $174 billion, and that estimate includes the $116 billion in excess medical expenditures, as well as almost $60 billion in reduced national productivity, people taking sick days, people being off work. 26% of people over age 65 have diagnosed or undiagnosed diabetes, so 1 in 4 people over the age 65 have diabetes. Patients with diabetes medical expenditures are 2.3 times higher than the expenditures that they would have in the absence of that disease. And approximately 10% of our healthcare budget is attributed to diabetes. That's including those indirect costs, which include absenteeism at work, reduced productivity, and lost productive capacity due to early mortality. An expensive disease indeed. When we look at mortality, we have 68,705 reported deaths due to diabetes, 22.4 deaths per 100,000 population. Diabetes is the leading cause of kidney failure and non-traumatic lower limb amputations and new cases of blindness among adults in the United States. So we see a lot of microvascular and we're seeing a lot of macrovascular complications due to type 2 diabetes. Diabetes is a major cause of heart disease and stroke, and it is the 7th leading cause of death in the United States. I want to share with you a bunch of my family diabetes experiences, and I do that just to show you that I am that age 55 pharmacist, and let's assume for the rest of the day I'm that age 55 patient. How are you going to approach someone that has this type of diabetes history in their family background? I'm going to start out with my grandma, Ositha Weinzierl, 100% German girl. She was a type 2 diabetic. She died in 1950 at the age of 56, and she probably died of kidney failure. We're going to talk about her daughter, my mom, Marie Kreckel. Mom was a type 2 diabetic. She was insulin dependent when she died. She died at age 72 from ovarian cancer, but she had 2 lower limb amputations. She had the FemPop bypasses, and eventually they amputated both legs because of her uncontrolled diabetes. My dad, Bud Kreckel, we'll call him, he was a type 2 diabetic. He died at the age of 75 of a GI hemorrhage. I also lost a brother to this disease, my brother Paul. He's about 3 years older than me. He was a type 1 diabetic. He died at the age of 52 of renal failure and stroke. And finally, my son Philip. Philip is a type 1 diabetic. He was diagnosed at the age of 17, and after 6 years of pump therapy, he was well maintained on Lantus and Novolog. He goes back and forth between the pump and the Lantus and log. They call it pump fatigue. Let's talk about Grandma. Grandma died 8 years before I was born, so these are stories that were shared to me by my grandfather as well as my mom. Grandma was a 1940s diabetic, keeping in mind that insulin was discovered in just 1922 at the University of Toronto by Banting and Best. NPH was not commercially available until 1950, so Grandma had to be using regular insulin. And I remember my mom saying they would fill her syringe twice a day with this insulin, and it hurt a lot. It caused a lot of lipodystrophy. I remember Mom saying that she had lumps on her. I'm sure it was very androgenic because it was either pork or beef at that time. They used glass syringes. They had reusable glass syringes. And yes, they even reused the needles that fit onto those syringes. I remember my grandpa, Joe, the blacksmith. Grandpa would tell me he would take her needles out to the garage and get a piece of emery cloth and resharpen them every couple days. And when we think back then, there was no monitoring of glucose levels either in the urine or blood glucose. So essentially what they did is they gave these patients a couple shots of insulin a day. It kept them out of diabetic ketoacidosis, but they had no idea what their serum glucose levels were. We're going to talk about Jerry. Now, Jerry's a 1960s diabetic. Wasn't a relative of mine, but he was our next door neighbor growing up. Jerry was diagnosed with juvenile diabetes in 1955, and I remember Jerry using NPH U80 insulin later on. And how well I remember early on in my career, as I'm sure some of us more seasoned pharmacists do listening to this presentation, remember the U40 and the U80, and finally the U100 insulin, and of course the matching corresponding syringes that had to go with each vial of insulin. Disposable syringes became available in 1962. So probably for the first 10 years of Jerry's diabetic life, Jerry was using glass syringes and screw-on needles. Test tape was used to monitor sugar in the urine in 1956. And keep in mind, all you can do when you're measuring sugar in the urine is to say there's sugar in the urine, which implies that the corresponding serum glucose level would be 180 or over. Whether it was 240 or whether it was 560 just depended on how you looked at the colorimetric chart that was on the side of the test tape box. But at least they had something to monitor whether there was sugar in the urine. So if he had positive sugar in his urine, he would know to either be a little more careful with the diet or ramp up his insulin a little bit. He had frequent hypoglycemic reactions. In this graphic I have here of a gentleman shingling his roof. When I was in 6th grade, Jerry and my dad were putting a roof on his porch, and Jerry went into an insulin reaction up on the porch roof. He was having seizures and convulsing up on the porch, and his wife dutifully helped get him in through one of the kids' bedroom windows, where he was given orange juice and carrot syrup, and he recovered quite nicely and couldn't wait to go back to finishing the roof. What Jerry did was he skipped lunch because he had all this good help helping him put the porch roof on, and it was very much to his detriment. Now you can imagine, back then I'm a 6th grade kid, and I see a neighbor having an insulin reaction up on a porch roof. Let's take a look at my dad, V.F. Kreckel. And the reason he was called Bud, I'm sure it's bothering everybody. His first name is Venantius. So with a handle like Venantius, everybody called him Bud. Dad was diagnosed as a type 2 diabetic in 1968 at the age of 54. His doctor, Dr. C, we'll call him at the time, looked at him and said, "Damn it, Bud, if you don't take off 50 pounds, I'm going to put you on insulin." My dad, being a hard-head, hard-nosed guy, immediately started dieting, watching everything he ate, and his weight decreased from 245 pounds down to 185 pounds within 1 year. When my dad died in 1990, he died of a GI hemorrhage. Dad weighed 185 pounds at his death because Dr. C said that's how much he should weigh. Dad was maintained throughout the rest of his life with good glycemic control with chlorpropamide or diabetes, 250 milligrams a day. Dad dutifully took that every single morning and never drank because of that, if you remember well, the antabuse-like reaction that diabetes caused. So Dad was very vigilant with his diet, never drank alcohol, and did very, very well. Never needed insulin because of that dramatic weight loss and his adherence to his medication. As we know with the treatment of type 2 diabetes, the first line treatment is diet and exercise, and it works through the mechanism of action of lowering blood sugar levels, improving insulin sensitivity, and it strengthens the heart. Strength training, which increases muscle and reduces fat, may be particularly helpful in patients with diabetes. Just diet and exercise alone, a patient, if they're vigilant with it, will lower their hemoglobin A1C by 1 to 2%. The American Diabetes Association does, however, recommend that metformin therapy be instituted at the very first visit where the diagnosis is made. A review of the adherence literature suggests that as a group, patients with diabetes are very non-adherent. Doesn't come as any surprise to us involved in patient care. In one study, only 7% of the diabetics were judged to be fully adherent with all aspects of the regimen. Keep that in mind the next time we have a new diabetic come into our store. Well, if diet and exercise are so important, and exercise being a big component, which is more beneficial, running or lifting? I was quite surprised when I read this study, the effect of resistance and treadmill workouts on hemoglobin A1C. And when we look at the slides on the right, the part on the right, we'll see that we have a dramatic increase post-intervention on the treadmill, but even more dramatic increase in lowering of hemoglobin A1C with resistant training, the weightlifting. And it's a very interesting study where they did just the 7 basic stations that we do at the gym, leg extensions, bicep curls, lat pull downs, all of those 7 big ones. They found with those patients that they had a more dramatic decrease in hemoglobin A1C. And on the bottom half of the slide, we'll see that we had a bigger percentage change when we did resistance training versus the treadmill. And that can be found, I have the reference, it's Diabetic and Metabolic Syndrome 2009. A very interesting study, well worth reading. Another incredible study was called Use It or Lose It. It was from the Journal of Applied Physiology, 2010 May. And what they did is they took these patients who had a very good activity level and they stopped them. After 2 weeks of reduced activity, 10 healthy young men decreased their daily activity level from a mean of about 10,500 steps a day down to 1,344. And that 10,000 steps, we're going to talk a little bit about it as a potential exercise regimen for our type 2 diabetics, down to 1,344. And I really suggest people put a pedometer on. I use about 1,300 steps a day working a 9-hour day in a retail pharmacy. I was quite amazed at how little I do walk in the course of a day. Their energy expenditure was reduced. Their body weight increased. We saw a decline in lean body mass in the trunk and legs. We saw a 6 to 7% reduction in cardiorespiratory fitness. But the big one that really surprised me was a 17% decline in peripheral insulin sensitivity. And my son Philip will tell you, when he's exercising vigorously, preparing maybe for a half marathon or doing a lot of biking, he will decrease his insulin usage by 1/3. So it is very important that we encourage diet for sure, but exercise will really help our patients with their insulin sensitivity. This data is particularly troubling because it appears even the young, healthy individuals cannot buffer the effects of the sedentary lifestyle even for 2 weeks. There's evidence that just adding 1 hour of exercise to a normal sedentary lifestyle will result in a 25% increase in insulin sensitivity. So even small baby steps are going to help our patients. The question always is how much exercise? We're not telling these people they have to spend 2 hours a day in the gym pumping iron. They need to do the little things. The first thing I think everyone should invest in is a pedometer. And you can get a really decent one online for about $35. And you can start them on this 10,000 step program. It requires a pedometer. I like the tri-axis ones. The tri-axis ones you can just shove in your pocket. Some of the cheaper ones you have to clip perpendicularly on your belt to the ground, and they might not be as accurate, but a nice tri-axis one for $35, slap it in your pocket or in your backpack, and away you go. I think that's a really good regimen to get patients started on, because first of all, when you take that pedometer to work, you'll see you'll get about 1,300 to 1,500 steps, and that's about it for most of us retail pharmacists. Another one that I encourage them to do, it's called the talk test. The talk test is a simple and reliable way to measure intensity. If you can talk and sing without puffing at all, you're exercising at a low level. If you can comfortably talk but not sing, you're doing a moderate intensive level. And if you can't say more than a few words without gasping for breath, that's your vigorous intensity. So tell your patients you'd like them to do it moderately so they're able to talk, but maybe not necessarily sing. If you heard my singing, you'd be glad that I wasn't. A number that I try to engrave in all of my patients, as well as even my Boy Scouts when we do that personal fitness merit badge, 3,500 calories equals 1 pound of fat. And I tell them to etch that into their brain. 3,500 calorie deprivation will cause you to lose a pound of fat. And an increase of 3,500 calories will help you to gain a pound of fat. It's that simple. Count the calories and you can adjust your weight accordingly. Lower calorie intake by just 500 calories per day, which is only 3 12-ounce Pepsis, full sugar, or any soda, you'll lose 1 pound per week. If you deduct 500 calories per day by exercise, you'll lose 2 pounds per week. Don't replace fat calories with carbs, and a nutritional consult is a must. So if we knock off 500 calories a day and we deduct 500 calories a day by exercise, that's 1,000 calories a day. That comes off as 2 pounds of fat per week. So it is really important to tell your patients that they have to do just baby steps. Get them moving a little bit with a regimen just by knocking off a couple sugared sodas a day, and they'll be able to achieve their goal. The challenge with diet and exercise, as we said earlier on, only 7% of those patients are going to be fully adherent. So for the other 93%, we're going to have to talk about medication therapy. We have a bunch of classes of drugs. We have sensitizers, we have secretagogues, alpha-glucosidase inhibitors, incretins, and incretin mimetics, of course insulin, and the new class of drugs, the SGLT2 inhibitors. I'm going to talk about one of my patients at the store. We're going to call him Jeff, not his real name, but Jeff is my 2010 patient. Jeff's a little younger than me. He's age 53. On October 26, 2011, Jeff presents at the local hospital emergency department early in the morning. His blood sugar is over 500. His hemoglobin A1C, when they measured it, 14.1%. His weight was 180 pounds. He's about 5 foot 8 inches tall, and calculating his BMI, it comes out to about 28. He was immediately started by the PA on metformin in the hospital, and it said you have to follow up with your GP today. That afternoon, Jeff goes to his physician. He comes to my store with a prescription for glargine insulin, which we dispensed as a vial of Lantus, an order for blood glucose home monitoring. You pick what you want, Pete. One Touch was preferred by his insurance, so that's what we started him on. Educated him on how to use the machine, the strips, and the lancets, as well as syringe disposal. We also provided him with syringes, and he started on lisinopril 2.5 milligrams daily to help protect his kidneys. 6 months later, because he was doing what he should have with his diet and exercise, and we kept reducing that Lantus dose, we switched him to Lantus Solastar pens, and he continues to report all his results to the pharmacist. A couple years later, February 2013, 18 months later, Jeff stops his insulin. He didn't need it anymore. On October 2013, 2 years after his diagnosis, we reduce his metformin to just 500 milligrams a day. He has a hemoglobin A1C of 5.7, which is fantastic. We always want it below 6. His weight is 150 pounds, which was really a 17% decrease in body mass, nothing real huge. And his BMI is now 23, which is in the middle normal range. Let's talk about some of these drugs. The first one that we put Jeff on was metformin, and we know that decreases hepatic glucose production, improves insulin sensitivity in the hepatic and the peripheral tissues. It's a liver drug. It primarily works on your liver to decrease that hepatic glucose output, and it also works in the periphery for glucose utilization. We'll see it lower the hemoglobin A1C around 1.5%. GI upset's a problem. We want to titrate this drug slowly, maybe 500 milligrams a day for a couple days, bump it up to 500 BID, try to get to the goal of 2,000, with the maximum dose being 2550, watching all along for lactic acidosis. The second class of drugs are the secretagogues. We're all familiar with them. They came out in the mid-50s, pretty much were derivatives of that sulfa molecule. They're the second generation sulfonylureas and glinides. The first generation came out in the 50s, and this second generation came out in the later 80s. So let's talk about some of these drugs. We have glyburide, available as Micronase and Diabetic, and glipizide, glucotrol, glimepiride, Amaryl, natiglinide, and repaglinide. They're those two fast-acting ones, Starlix and Prandon. They're considered second-line therapy. They're considered to be just add-on therapy for metformin. They're very inexpensive, so we see those used a whole lot in my practice. We'll expect the hemoglobin A1C lowering of 1 to 1.5%, and again, they push more insulin out of the pancreas, is what I tell the patients. The side effect, because of that insulin, is going to be hypoglycemia and weight gain, and they're considered to be second-line, but the glyburide is considered a second-line choice of this group because of the potential for hypoglycemia. So we're not going to use glyburide on any of our elderly patients because glyburide in 2002 was put on the Beers list. So we're not going to be using glyburide in our elderly patients. And the truth is, I think most physicians have backed far away from glyburide because of that potential for hypoglycemia. Sensitizers seem to have fallen out of favor a whole lot. The Avandia is available only as a specialty pharmacy item. And Actos, we're not using a whole lot of it these days either. They work on that PPAR gamma receptor. These are your muscle drugs. These will work in your periphery more than the liver. Their main action occurs in the muscle tissue, and they increase insulin-stimulated glucose disposal. It takes about 6 to 14 weeks to see maximum effect. They work a little bit in the liver. They do cause some heart failure. That's the problem with Avandia, increase in fracture risk, and we know that Actos has been implicated in bladder cancer. So if a patient does get Avandia therapy, they're going to be getting it through the Avandia Medicine Access Program that's available from the manufacturer. We don't use a lot of alpha glucosidase inhibitors in my practice either, and I think a lot of pharmacies don't use much of it. Acaribose and Miglitol are available, and what they do is they inhibit digestive enzymes, maltase, isomaltase, sucrase, and glucomaltase, and what they do is in the intestine they disrupt the breakdown of oligo and disaccharides into the monosaccharides that are more absorbable. They delay the digestion of carbohydrates. They're weight neutral. They cause a lot of GI upset, a lot of flatulence. They can cause some diarrhea, some abdominal discomfort, and we'll see about a 0.5% lowering from the alpha glucosidase inhibitors. Let's discuss for a slide or two the concept of insulin resistance. It occurs when the body does not respond properly to its own natural insulin. And insulin is a hormone that we have in our bodies that helps convert blood sugar to energy, so it can be used by the body's cells. And in those individuals with insulin resistance, the pancreas tries to keep up with that demand for insulin by pushing out more and more insulin from the pancreas. And eventually the pancreas just cannot keep up with the body's need for insulin, and we have an accumulation of excess sugar in the bloodstream. The pancreas is pushed to the maximum, pouring out all the insulin it can, and blood sugars continue to spiral up. I tell my patients their pancreas just becomes tired. In a healthy adult patient like myself, hopefully non-diabetic, beta cells are going to fail at about 0.3% per year. And so you can tell your patients they're going to expect to lose about 3% of their beta cell function over a 10-year period. In an adult patient with type 2 diabetes, the beta cell failure rate is about 4 to 6%. So uncontrolled, they're going to lose 40 to 60% of their insulin-producing capabilities in 10 years. So it's fair to say that if a patient develops type 2 diabetes early on in life, if they live long enough, they're going to need insulin therapy. And I think this is a huge concern with this obesity epidemic of the younger people, the 20-year-olds that are presenting with type 2 diabetes. We can see that they're going to live long enough. They will all require insulin therapy, those younger diabetics. Let's turn the tables, and let's assume now that I am, at age 55, a newly diagnosed type 2 diabetic, and my hemoglobin A1C is 14, and you want to start me on insulin therapy. There are a lot of challenges you're going to have to address, especially with my history. Now, of course, people are going to think of needle phobia, the perception of failure, lifestyle modifications. I have to change up everything. I can't go to the restaurant anymore. This is going to cost me a small fortune. I know how much those test strips cost. There are cultural biases, especially with the Hispanic community. They're not fans of insulin. But the biggest fear that a type 2 diabetic is going to have is hypoglycemia. And especially a guy like me that saw Jerry having an insulin reaction up on the porch roof, I'm going to have needle phobia because I'm going to think about sharpening insulin syringes with a piece of emery cloth. So people my age, because of their history and what they've seen as a young kid, are going to be a real challenge to start insulin therapy. Let's talk about the institution of insulin therapy for a type 2 diabetic. Insulin can be instituted at any point for a type 2 diabetic, like we had to for Jeff at his first visit, and it should not be considered as a last resort for the treatment of the disease. Consider insulin as initial therapy if they're severely hyperglycemic, if they have a blood sugar over 250, or a random glucose level consistently over 300, or a hemoglobin A1C of greater than 10%, by default, we should start insulin on those patients. Most prescribers are going to introduce the long-acting peakless insulin once a day, and the two most common that we'll see today are insulin glargine, available as Lantus by Sanofi Aventis. That has a duration of action of 24 hours. And insulin detamir, Levemir by Novo Nordisk, which has a duration of action of about 16 to 20 hours, up to about 24 hours maximum. This next slide will show you what we're going to have to do when the basal insulin, the Lantus or Levemir, or even Ultra Lente for the old timers, when that just isn't enough. And we have the bottom axis going from the left to the right is showing a progressive deterioration of beta cell function. We're losing more and more of the ability of that tired pancreas to even produce insulin. So the first level we're going to do is lifestyle changes, then we do the oral monotherapy, and then on the third step we might be adding basal insulin and titrating it. The next step up the ladder is going to be a new concept called basal plus one, where you're going to add one injection of rapid insulin, one of the logs, either Novolog, Humalog, or Apidra, the rapid acting insulin to their main meal, their biggest meal of the day. They're going to take a shot of the rapid acting insulin. And then we'll try that for maybe a couple months, hopefully for a few years. That'll be effective before we need to step up to basal plus 2, and then eventually the basal plus 3 prandial shots for a total of 4 injections a day, the basal bolus. Most of us know the story of the Incretin Mimetics that were found in the saliva of Gila monsters. That's why I have that cute little Gila monster on the top of this slide. And your incretins mimic your natural physiology to provide self-regulating glycemic control. It helps enhance insulin secretion only in the presence of hyperglycemia, of high blood sugar levels. GLP-1 stimulates the pancreas to increase insulin and blunt the effect or decrease the effect of glucagon secretion. You're going to see a weight loss and no hypoglycemic. That's what makes these so favorable. Insulin secretion decreases as the blood glucose concentration approaches normal. We're going to see a pretty good effect with these, 1 to 1.5% lowering of the hemoglobin A1C. They do cause headaches, they cause a lot of nausea and diarrhea, and have been implicated in causing pancreatitis. But this helps your own body's still produce its own insulin and make that insulin a little bit more effective. It slows gastric emptying time so you don't get those real big postprandial spikes as well. And those available products, the Incretin Mimetics, they suppress the elevated glucagon secretions during periods of high blood sugars and to reduce food intake. People see a dramatic weight loss with these. It slows that gastric emptying time. It keeps our patients fuller longer and seems to help with the insulin, blunt the effects of glucagon. Sounds like a great drug. The Byetta is available. Victoza is once a day. And the Bydureon is dosed just once a week. So we went from dosing Byetta twice a day down to once a week with Bydureon. Those incretins are broken down by DPP4, which is dipeptidyl peptidase, and we now have the DPP4 inhibitor drugs, and they reduce the breakdown of the endogenous GLP-1 by inhibiting the action of DPP4. DPP4 rapidly degrades the endogenous gliptins, so the net effect, it increases insulin release, blunts the effects of glucagon, increases the gastric emptying time. Our patients feel fuller longer, and the good news is they're weight neutral. So when we look on this next slide, it's a little description of how gliptins work. The first thing we look at is the green oval where it says the incretins or the GLP-1s. And the good effects of them, they stimulate insulin release, they inhibit glucagon release. Remember, glucagon's that hormone that drives up blood sugars. And by blocking glucagon and stimulating insulin, we have a lowering of blood glucose. So DPP4 inactivates those incretins. So when we go down to the blue rectangle, we'll see that the DPP4 inhibitors block DPP4 and then have that net effect of increasing the incretins. The advantages of gliptin therapy is they're oral medications, so we're not dealing with needle phobia. There's no titration required. There's no hypoglycemia. They're weight neutral. They're very well tolerated. They stimulate insulin production with little risk of corresponding hypoglycemia. There's less risk for cardiac events than the TZDs. No injections, no needle phobia, and no cumbersome training as you have to with the Bydureon. And those available DPP4 inhibitors, we have sitagliptin, saxagliptin, linagliptin, and alogliptin. And all of those are available in combination as a single pill with metformin. I have those all listed for you. The trade names that us retail pharmacists and our techs are most familiar with are Januvia, Onglyza, Tradjenta, and Nesina. That being said, all four of those gliptins are not created equally. I have the chart here on the left-hand side. We have the creatinine clearance listed, and then I have the four drugs listed across the top. And you can analyze this in your free time, but basically Tradjenta or linagliptin does not require any dosage modification regardless of the creatinine clearance. They also do not require any adjustments based on cytochrome P453A4 drugs administered at the same time. We can see that Januvia we have to adjust for creatinine clearance. Nesina has to be adjusted for creatinine clearance, and Onglyza needs to be adjusted between its two doses of 5 and 2.5 based on creatinine clearance. And we now have a brand new drug, brand new mechanism of action. They're called the SGLT2 inhibitors, and the SGLT2 inhibitors effectively work to reduce blood glucose independently of insulin. Everything we've talked about up until this point, whether it's metformin, whether it's the sulfonylureas, whether it's the gliptins, whether it's the incretins, all of them you have to have insulin to make it work. This class of drugs works independently of insulin, and how it works is in the kidneys. And in the kidneys, we have our glucose resorption, and that plays a really important role in glucose balance. The kidney filters about 180 grams of glucose every day, with virtually all glucose being recycled back into the circulation. And the only time that we have spilling into the urine is when we saturate that enzyme system. We'll get our sugar spilling into the urine, and that happens, as I said earlier on when we were talking about test tape, at about 180 milligrams per deciliter. SGLT2 is a major sodium glucose co-transporter in the kidney, and it is insulin-independent pathway for the reabsorption of glucose back into the blood. Selective inhibition of this SGLT2 causes us to excrete glucose into our urine, something that all of us pharmacists have learned from very early in our careers. Sugar in the urine is bad. And this is a re-education, especially for me too, to learn that now sugar in the urine is a good thing. And the SGLT2 inhibitors help us to remove that sugar via the urine. The positive effects of the SGLT2 inhibitors, we have no hypoglycemia because, again, it works independently of insulin. It can be used as monotherapy or added on to metformin, and we'll see reductions in blood pressure of all things. We'll see a reduction in blood pressure of 3 to 5 millimeters of mercury systolic and 2 millimeters dystolic. There's no change in heart rate, there's no syncope, and we do see a pretty significant weight loss. We are going to be losing 50 to 85 grams of glucose, which equates to about 200 to 350 kilocalories per day. So if you had a patient on an SGLT2 inhibitor, knowing now that 340 calories they're going to lose per day, and 3,500 calories is a pound of fat, within 10 days they should lose a pound. The SGLT2 inhibitors, also called glucuretics, there's a couple more in development as well. The first one to be released was Invokana by Johnson & Johnson, canagliflozin. And pagliflozin is still under study, as is dapagliflozin. The SGLT2 inhibitors cannot be used in stage 4 nephropathy. When you have a glomerular filtration rate of less than 30, you can't use them, and that's no surprise because of its mechanism of action. The concerns that we saw in the phase 3 trials, dapagliflozin had a 4-fold increase in the risk of developing breast cancer, and male diabetics had a 5 times the risk for developing bladder cancer. Canagliflozin had higher cholesterol levels and hypoglycemia rates, genital infections, and blood pressure and increased urination. So you saw a couple things that were a little bit disturbing and not really a surprise. When we see all that sugar in the urine, we would probably expect to have a little bit of an increase in genital infections and yeast infections. A lot of the docs seem to see from their experience, though, that they only get about one genital infection. Keeping in mind, of course, all along that frequent yeast infections is a sign and symptom of type 2 diabetes, whether they're on SGLT2 inhibitors or not. Empagliflozin saw an increase in urinary tract and genital infections as well, usually categorized as mild. It's fairly evident with all of these drugs and their different mechanisms of action that combo therapy seems to creep up into every diabetic's therapeutic regimen. Even with drug treatment, your type 2 diabetics will eventually need additional therapy to treat their hyperglycemia. After just 3 years, 50% of your patients are going to need that second drug. After 9 years, nearly 75% of your patients are going to need that second drug. The most common combination that us pharmacists are very familiar with are the sulfonylurea plus metformin, both of those being very inexpensive drugs. As that diabetes progresses, a third drug is often added, either an oral agent, exantide, Byetta, or insulin. Addition of insulin should not be postponed in patients with poor glycemic control that have failed on multiple drug regimens. We should probably be jumping on insulin a whole lot quicker than we are. Let's take a look at combination therapy for type 2 diabetics. At the first appointment, when the diagnosis of type 2 diabetes is made for a patient, we want to begin lifestyle modifications, diet and exercise, as well as metformin therapy. Now, keeping in the back of our minds, only 7% of our patients are actually going to follow through with those lifestyle modifications for an extended period of time. 93% of the time, they will not. We still never give up. We still need to encourage lifestyle modifications. After 3 months of metformin and lifestyle modifications, if they're not at that A1C goal, we'll probably have to add that second drug. And that second drug can be a second-generation sulfonylurea for a reduction of 1 to 1.5%, a DPP-4 inhibitor of 0.5 to 1%, a GLP-1 agonist of 1 to 1.5%, or we can add insulin. And after 3 months, if we're not at the A1C goal, we can consider adding a third drug. It's a simple math problem is what I tell my students at St. Francis. It's a basic addition problem. If a patient like Jeff comes into our clinic and they have a hemoglobin A1C of 14 and we want to drive that down to 6, there is no 3-drug combination on this list that's going to give us the 8% lowering that we need. When we look at diet and exercise at up to 2%, metformin's at 1.5%, the second-generation sulfonylureas is 1 to 1.5%. The DPP-4 inhibitors will get 0.5 to 1%. The GLP-1 agonists are 1 to 1.5%. Just 0.5% for our alpha-glucosidase inhibitors, our TZDs, our SGLT2s. But the most bang for the buck, that's your insulin. We're going to see that that causes the greatest effect in lowering hemoglobin A1C levels. However, it's going to cause the most weight gain. The effect on weight is going to be weight increases for our insulin and our second-generation sulfonylureas. That only stands to reason because the second-generation sulfonylureas are pushing more insulin out of the pancreas. More insulin equates to more weight gain. As far as effects of hypoglycemia, we'll see also our second-generation sulfonylureas and our insulin will cause hypoglycemia, but the rest of them will not cause hypoglycemia. A very good benefit for our diabetics, knowing that the hypoglycemia is the biggest fear that they have, be it of insulin therapy or second-generation sulfonylureas. Let's talk about the teamwork approach to type 2 diabetes, and this is something we pharmacists are going to take a bigger and bigger role in as each year continues, as we get more diabetic patients who require more monitoring. The pharmacist's role right now is to reinforce adherence to all medications. Make sure your techs are taking a look at late refills and informing you so you can go out and talk to those patients and reinforce to them the need to take their medications. Reinforcing the insulin therapies if prescribed. Insulin storage information is always a big question, and patients just are clueless with this. Very frequently, they don't realize they can take that pen that's in use and they don't have to refrigerate it. A lot of people will say, well, I want to go to a ball game. Do I have to take a little cooler with my insulin in it? It's a very big weakness is the storage of insulin. Which is better, vials or pens? Well, it depends on our patients and how much insulin they're using. Blood glucose meters and monitoring, there's a lot of insurance issues. We don't seem to have trouble getting the free meters, but getting the test strips paid for can be a big challenge. The differences between mealtime versus basal insulin. Back when everyone was using NPH and regular, you had your cloudy insulin was your long-acting, and your clear was your fast-acting. Well, today, with Lantus being clear, it becomes more of a challenge for our patients. They have to know the names of their medications to know which is the mealtime versus the basal insulin. Syringe disposal can be a huge issue. We have to reinforce to our patients how to do that. Hypoglycemic issues and their treatment need to be discussed as well. We need to help our patients monitor for drug interactions with the medications that they're taking, and we have to provide information to clinicians on that cost-effective, evidence-based prescribing. We are the go-to guys as far as the drugs and the mechanism of action, but we are critically important when it comes to affordable medications. When we talk about just vials and pens, pens are a better option because each pen can be left out of the refrigerator for 28 days. You figure there's 300 units per pen, and there's 5 pens per box. So if you have a patient that's taking 15 units per dose, they can get 20 days per pen. Or of those 5 pens, they can get 100 days out of a box. They can only get really 28 days worth of therapy out of a vial once they break into it, because Lantus should be discarded after 28 days. So we can talk to our clinicians and say, hey, they're only using 15 units per day. They can get 3 times as much bang for their buck out of a prescription if we pick the pens for those patients versus the vials and the syringes. How can we get more than 7% adherence under 7%? The pharmacist's role is going to be to monitor refill history. We want to encourage diet and exercise along with adherence. How many of our pharmacies have scales in them for the patients to weigh themselves? It's okay, my store doesn't either. Use combination therapy where available just to decrease the numbers of copays. The Glucovance, the Janumet or Genta Duetto, that'll all help with those cost issues. The management of hypoglycemia. We have an expertise in OTC selection. Should our diabetics be avoiding Sudafed if it's spiking up their blood sugars? And patient counseling on storage, travel issues with insulin, and all the oral meds are a level of expertise that the pharmacists truly have.